Welcome to my case study. So my patient today is Mr. Johnny Depp. He's a 55-year-old male who is married. He's worked at a power plant for the last 30 years. He's been married for about 15 years. He's an ex-smoker. He stopped smoking about 10 years ago. So he may have some gingival issues due to the amount of time that he did spend smoking. What's interesting about his history so far is that in working at the nuclear power plant for so many years, he's been exposed to a lot of industrial solvents and also a lot of magnetic fields from the power plant itself. And that, in addition to the fact that he has a history of drinking, he has a history of smoking, so he does have some cancer risk factors. And so unfortunately it looks like he has come down with leukemia. So in order to treat his leukemia, Mr. Depp is on a number of different treatments. He has had to undergo chemotherapy, which is a cocktail of many different drugs. One of the main drugs prescribed for that is midostaurin. And another treatment that he's had to undergo is radiation therapy. And he had to have his immune system compromised. He takes cyclosporin in order to fight graft versus host disease from having a blood stem cells transplant, and also takes prednisone, which is a very common medication for leukemia as well. So the dosages are listed here. He also has visual impairment. Visual impairment itself doesn't have any bearing on his oral condition. However, the condition of leukemia, in addition to the medications that he's taking, have contributed to his visual impairment because it's caused glaucoma, increased intraocular pressure, and may also lead to cataracts down the road. So he is also taking Diamox for the glaucoma and Travatan. Okay, so there's a multitude of side effects to these medications. The leukemia medication causes mucositis, vomiting, increased risk of infection, malnutrition, xerostomia, ulcerations, and gingival hyperplasia. One of the medications for the glaucoma just basically causes altered taste. You can see from his probing chart that he does have quite a bit of bleeding and inflammation. He has very good oral home care and had a very low plaque index, but due to the medications and the conditions that he has, he does have a lot of inflammation that he's unable to fight off. He's got generalized bleeding throughout, and he's got higher probing depths in the posterior. Like in the upper left, he has some 5s and 6s. He's not too bad on the upper right. On the lower left, he has some 5s, also with the furcation. And on the lower right, he has some 5s with 2 furcations there. For the AAP periodontal classification, he does have gingival disease. It would be classified as 1B because it's not plaque-induced. It's caused by systemic disease and medications. Nutrition can also play a part. If he's vomiting, he can't always get the right amount of nutrition. Makes it hard to fight things off. Plus, vomiting can make for a very acidic environment in his mouth. So he does have chronic periodontitis, and generalized he has slight periodontitis, and localized he has moderate periodontitis. And in section 4, we have it caused by Perio systemic disease. He has a systemic disease of leukemia, which is also a hematological disorder because it's a disease of his blood. And he has no abscesses. He's not endodontically involved and has no deformities. So for the ADA case type, he's actually a case type 2 and a case type 3. He's generalized case type 2 because in most of his mouth he has 3 to 4 millimeters of probing. He does have bleeding, so normally that would go along with gingivitis, but he does have slightly more probing depth, so that brings it to case type 2. He does have some recession on tooth numbers 6, 7, 10, 22, 27, and then 28, 29, 30, and 31, the entire lower right. And he does have a class 1 furcation on number 31, which falls under case type 2. And he's got alveolar bone loss 2 to 3 millimeters below the CEJ, 1 to 2 millimeters of clinical attachment loss, and up to 15% of radiographic bone loss in most of his dentition. For case type 3, he has 7 out of 27 teeth involved, which is 26%, falling under localized, with 5 to 6 millimeter probing depth, bleeding, recession, furcations of class number 1 and 2. He's got a class 2 furcation on number 19 and 30, class 1 furcation on number 31, and slight mobility on number 30. So in the posterior area, he's got alveolar bone loss 34 millimeters below the CEJ, horizontal and vertical bone loss 3 to 4 millimeters of clinical attachment loss, a visible furcation, and 16 to 30% of radiographic bone loss in those areas. So in describing his gingival condition, the gingival color appears bright red from the free gingiva to the papilla and the attached gingiva, with areas of blanching in the anterior, maybe due to smoking. His gingival contour presents as moderately rolled and rounded throughout, with areas of recession and severely bulbous-shaped papilla. Gingival consistency presents generally as moderately soft and spongy with severe swelling, and the surface texture presents as shiny with severe loss of stippling throughout the dentition. So Mr. Depp's case type is ADA generalized case 2, localized case 3, modified by systemic disorders of leukemia and medications. His AAP classification is that the patient presents with generalized non-plaque-induced gingival disease due to medications and treatment he received for leukemia. Patient has chronic generalized slight periodontitis with localized moderate periodontitis in the posteriors. Under his ADA case type, patient presents with generalized bleeding and inflammation throughout the dentition, with pseudopocketing in the anteriors as a result of immunosuppressant medication, cyclosporin. Generalized 3 to 4 millimeter probing depth in alveolar bone 2 to 3 millimeters below CEJ with recession, and localized 5 to 6 millimeter pocketing in the posteriors. Grade 1 furcations on 31, Grade 2 furcations on 19 and 30 with class 1 mobility. Radiographic findings show localized areas of bone loss 4 to 6 millimeters below the CEJ in the posterior region. gingival descriptive statement we already went over. Bright red throughout from the free gingiva to the papilla. Blanching in the anterior. And the margins are rolled and rounded. And receding mainly in the canines and the right side molars, and severely bulbous shaped papilla. Consistency is moderately soft and spongy, severe swelling due to the medication, and the surface texture is very shiny with severe loss of stippling throughout the dentition. So on our first slide, we've got a left molar bite wing shot. So we're showing that he's missing number 16 and 17. Okay, and also number 15. So we see the vertical bone loss, which is around number 12 and 13. Deep pocket between 13 and 14. There's a couple of little spicules of calculus showing. In the lower premolars, you see that it's 3 to 4 millimeters below the CEJ, whereas further back you get to 5 to 6 millimeters below the CEJ. And it shows the horizontal bone loss on the lower region. And you see that the lamina dura is gone. There's no more crestal bone. And you can see the radiographic grade 2 furcation. In our first gingival image, we can see on the maxilla the severely bulbous papilla. It's also very shiny, blanching in the anterior. And on tooth number 10, you can see that there's an active infection with suppuration. And number 11 and 12 area, you can see the severe swelling there, as well as throughout. And you can see the recession on number 22, 27, number 6 and 7, and 10 in this photo. In this photo, you can see one of the reactions that he's having to his meds. The cyclosporin that he had to take after he had the stem cell transplant after the radiation therapy. So the gingiva is extremely swollen there from the medication, and due to all the swelling, there's no more stippling, everything's very shiny. So certain types of leukemia, as you see, they may spread to the gums, causing swelling, pain, and bleeding. So you can see the ulcerations in this photograph. The recession showing around tooth number 6. And the painful red areas, the ulcerations around 6 and 7. And also around 9, 10, and 11. And it looks like over number 7, he's developing root caries from xerostomia, which may have been brought on by the radiation treatment, or may also be brought on by the medications that he's taking. Pretty much everything he's going through is going to be exacerbating the xerostomia for him. So in the next photo, it shows how some of the issues may have started beforehand, because he was a smoker for many years and then he stopped smoking. A lot of times smokers won't show redness or bleeding as much. So it looks like some of his bone loss started early on as a result of the smoking. It shows his furcation and the recession around the posterior teeth. Now this area is much more swollen and red, but this is an earlier photo from when his disease first started. Once he stopped smoking, he started taking care of himself with excellent home care, moderating his alcohol intake, eating better. But now that he does have the diagnosis of leukemia, it's going to be a lot harder for him to get by. So his prognosis really depends. I would range it from fair to poor depending on the location, because he has two issues going on. He had some bone loss beginning from when he was smoking, but then he stopped the smoking. Now that he's got the disease and he's taking medication, it's starting up some gingival conditions all over again. So since the problem originated in the posterior region, it's actually progressed further in the molars than it has in the anteriors. So a lot of the problems that are going on in the anteriors is mild and can be corrected. Swelling, pseudopocketing. So that can be corrected if he's able to get well, go into remission, get off some of the medication, and practice good home care. Then he will be able to get the anterior region back to normal, back to a disease-free state. So that's why I would basically rate the anterior area as fair and poor prognosis in the posterior region, because that's more of a class 3. It's getting to where he's got a 1-to-1 ratio of bone, tooth to bone. A lot of factors are beyond his control. He does have the systemic condition. The disease itself and the medications and the treatment that he does have to undergo negatively affects his oral environment despite his good hygiene. So the outcome is just going to depend on how soon he can get over this disease and go into remission. And so as long as he continues with good home care, needs to make sure he keeps up with his recall visits and does not skip a visit, and keep up with the fluoride treatments. Professionally will be giving the fluoride, but also he will keep up with fluoride at home, and he will be using a saliva substitute to help out with the xerostomia so he can keep those root caries at bay. Long-term goals are going to be more frequent visits every 3 months at least. He'll be coming in, and hopefully he'll go into remission and be able to discontinue his medications. The modifiable risk factors were smoking, which he did stop, and alcohol status, which he has cut back, his nutrition status, home care, and keeping up with the recall visits. The non-modifiable risk factors are the disease of leukemia and the medications to treat leukemia, the chemotherapy treatment, which includes midostaurin as one of the medications, cyclosporin for anti-rejection, prednisone, and radiation treatment. So his treatment plan is going to include an initial exam where we're going to go over everything, and then he will go through a periodic exam twice a year. He may need a preliminary debridement at some point in time. At this time, calculus is not a big problem, so we're more going to worry about perio maintenance visits. There could be a case made for gingivitis therapy. However, that's controversial since he does have the attachment loss, but he does have a severe case of gingivitis that needs to be brought under control. And because he does have the risk of infection and does have active infection over tooth number 10, we're going to deliver antimicrobials subgingivally, and we're going to do gingival irrigation to really flush out the area. We're going to be doing periodontal maintenance at least every 3 months. For prevention, we're going to be doing the topical fluoride varnish. And miscellaneous procedures, of course, we're going to go over OHI at every visit and visit any kind of barriers or problems he may be having. So this is just the same thing, the flow chart showing the exam to start with, the preliminary debridement if needed. If not, we would go straight to the Perio maintenance, gingival irrigation, and localized antimicrobials, and the fluoride and OHI. These are the instruments we would select. He doesn't have a lot of calculus, but he does have some deeper pockets. So we've got the Gracies, the mini Gracies, which are the after 5 instruments, and the mini 5s. And we can use standard. Okay, and it shows the 1, 2, and the 5, 6 for the anterior region, the 7, 8 for the premolars, the 11, 12, and 13, 14 for the posterior. We're not needing the rigids for the fact that he has a lot of calculus, but since he has deeper pockets, the rigid instruments are going to let us go deeper without the instrument bending and flexing, so that way we can maintain the precise angulation when we get close to the root surface. Scalers, standard, fine scaling of calculus if present. We're not going to need a whole lot with scalers here. Ultrasonic, definitely, because his gingiva is going to be so tender and so fragile. It's really a gentler way to begin with debridement and getting off any calculus that is there. So we're going to use the 1000 triple bend for any areas of calculus. Go around with the 100 if we need to. The slimline 10 is going to get a little bit deeper into the pockets. We definitely want to use the left and right around the root furcations, and the thin third if we want to get into the really anterior region and get down into the pocket without having to cause any distension of the tissue. So for home care recommendations, we've got the 5% fluoride varnish that we're going to be applying at each dental visit. We're going to prescribe the ClinPro 5000 along with the instructions of how to use that. The Periomed stannous fluoride rinse and the chlorhexidine to rinse with. And over the counter, you can use biotin and spry. If using a manual toothbrush, he's going to use the Bass technique twice a day, and that's going to be for at least 2 minutes. And to use extra soft brush and brush very gently around the gums because they're ulcerated. The toothpaste, once again, he's going to be using the prescription ClinPro 5000. And for floss, he'll use the Listerine and proxy brushes if he has any wide embrasures he needs to get through. And under mouth rinses, once again, the Periomed and the Paradex. We'll be using the stannous fluoride in the morning under special instructions, stannous fluoride, and rinse each night with the chlorhexidine. That way you're not using both at the same time. Fluoride, once again, varnish. And what to avoid flossing too vigorously, can irritate the inflamed gingiva and cause clefting. Nutritionally, he does have some challenges. After he quit smoking, he was taking care of himself, getting exercise, doing fine, but now that he has this condition and he's taking these medications, he does have some problems with nausea and problems eating certain foods. So we're just going to concentrate on fresh, non-processed foods, increasing fruits and vegetables. Those have a lot of a lot of nutrients that help fight cancer, decreasing salt and not using potassium supplements, and avoiding cured meats, deli foods like soft cheeses, pate, aged cheeses, raw or undercooked meat, fish or eggs, and raw sprouts. Those are things that can really affect his immune system at this point with what he's going through. And he'll be taking multivitamin and supplements with extra vitamin C, D, calcium, phosphorus, and folate. The end.